This is Neil Pasricha from UCSF. In this video, I'll explain my surgical approach for a patient with a history of 50-cut radial keratotomy in both eyes, referred to me for cataract surgery. Given the limitations of IOL formulas in post-RK patients, we elected to proceed with a light adjustable lens. Now let's see the cataract surgery with LAL in the patient's right eye. Despite 50 cuts, the view of the cataract was reasonable. A subtenon block was administered. Limited temporal conjunctival peritomy was performed, followed by a eraser tip cautery for hemostasis. A paracentesis was performed posteriorly at the limbus, in between RK incisions. Lidocaine and epinephrine were administered, followed by trypan blue dye. The anterior chamber was filled with dispersive viscoelastic. 3 millimeters was measured using calipers, and a short scleral tunnel incision was fashioned, entering the anterior chamber just posterior to the RK incisions. A 5 millimeter continuous curvilinear capsulorhexis was created, taking my time to really float in the scleral tunnel to avoid burping out viscoelastic or straining the RK incisions. Hydrodissection was performed and a small aliquot of additional visca was injected into the anterior chamber. A non-stop phaco-chop technique was used for nuclear disassembly. The phaco IOP was lowered to 40 millimeters of mercury to avoid splaying of the RK incisions and leakage. Thankfully, the anterior chamber was stable in this case, and the moderately dense lens was removed without issues. Coaxial irrigation and aspiration was performed, being careful to remove any residual lens pieces from the paracentesis and the sulcus. Gentle capsular polishing was performed. The bag was reinflated with cohesive viscoelastic, and the incision was enlarged to 2.8 to 3 millimeters. The RX site cartridge was filled with cohesive viscoelastic, including spreading over the edges. The LAL is handled gently by the haptic, with the leading haptic placed inside the cartridge prior to folding the LAL. The cartridge is then loaded into the RX site injector and injected into the bag. Viscoelastic is removed, and care is made to avoid touching the optic and to ensure any residual lens fragments are removed. The scleral tunnel is sutured with 10-0 nylon, and the knot is buried. The conjunctival peritomy is closed with a single buried 8-0 vicryl suture. Intracameral antibiotic is administered, then a fluorescein strip is applied over the entire cornea to ensure all the RK incisions are side-L negative. A tetracaine-soaked Wexel is applied, followed by subconjunctival steroid. Post-operatively, our patient had mild visually significant PCO, so I performed a YAG capsulotomy at post-op month 1. Despite the 50 RK cuts, the LAL light delivery device was able to successfully administer the UV light treatments without issues. Our patient had 2 LAL adjustments and 2 lock-in sessions, ultimately ending up very happy with minimal residual refractive error. His uncorrected distance visual acuity was 20/20 in the right eye and 20/25 in the left eye. Thanks for watching.